and welcome to the Hypertension Series. This is volume 1 of a series of talks on hypertension, which were held during the meetings of the Hypertension Task Force. The object of this series is to review available data and allow the individual physician to determine what is known, what is unknown, what is reasonable, what is unreasonable, what can be concluded from the data and what is not supported by the data, and how do we ultimately use all of this data to benefit the patient and to produce the best outcomes in terms of hypertension, in terms of cardiovascular outcomes, in terms of chronic kidney disease, in terms of dementia, in terms of neurological outcomes, etc. The first talk in this series will be a general introduction about the goals of this series and what we will achieve through this series. And then ultimately after that, we will go into the KDIGO guidelines, the individual trials. We will discuss the importance of genetic testing and what other tangents there are that we should know about and implement in our daily care of the patients. So what are the goals for this series? The goal is to gain a comprehensive perspective about hypertension within which to nestle the effective clinical management and monitoring of blood pressure. Comprehensive perspective includes understanding results of hypertension trials and grasping their applicability to clinical practice, understanding KDIGO guidelines, kidney disease improving global outcomes guidelines, and understanding the pathophysiology of hypertension. This series will consist of 15 to 20-minute talks at the beginning of each meeting of the Hypertension Task Force every third Tuesday of every month. The series will begin with a synopsis of the kidney disease improving global outcomes, KDIGO hypertension guidelines. Then we will review each hypertension trial to realize its significance as well as its drawbacks, including the ACCORD trial, the SPRINT trial, the SHEP, SP3, MDRD, ASK, RHINE2, and other trials. Thereafter, we will discuss resistant hypertension, the importance of low renin essential hypertension, as well as the role of spironolactone. Finally, we will review sodium handling by the kidney, channels and transporters in the kidney that play a role in hypertension, as well as common genetic predispositions, including ApoL1, which mediate hypertension. Hypertension is a burden. Hypertension affects nearly half of the adults in the United States. An estimated 1.28 billion adults aged 30 to 79 years worldwide have hypertension. Hypertension is a leading cause of cardiovascular disease, stroke, and kidney disease, contributing significantly to mortality and disability-adjusted life years lost worldwide. Let's review the annual data for the United States. Number of visits to physician offices with essential hypertension as the primary diagnosis, 56.8 million. Percent of visits to physician offices with essential hypertension indicated on the medical record, 33.2%. Number of visits to emergency departments with essential hypertension as the primary diagnosis, 1.3 million. Number of deaths from essential hypertension and hypertensive renal disease, 43,293. Deaths per 100,000 population from essential hypertension and hypertensive renal disease, 13. So first, let us quickly review the guidelines set by KDIGO and appreciate why its recommendations are slightly different from American Heart Association, from American Diabetes Association, and European organizations to get a broad perspective on hypertension goals. Then let us go through the major hypertension trials so that we're not blindly following guidelines, but are establishing goals and implementing standards of care because we agree or disagree with available data or lack of available data and/or expert opinions. Finally, let us review the pathophysiology of hypertension. I'm going to talk about this last because even though it's important to discuss pathophysiology, I think the momentum will be greatest if we appreciate how hypertension can be clinically immediately impacted in our lives first, rather than deal with pathophysiology, which is perhaps more remote and less practical. Let us begin. So this is just a quick snapshot of chronic kidney disease. We all know there are five stages of chronic kidney disease. Uh, Normal is a GFR of greater than 90. Mildly decreased is GFR of 60 to 89. Mildly to moderately decreased is 45 to 59. Moderately to severely decreased is 30 to 44. Severely decreased is 15 to 29. And less than 15 is stage 5 chronic kidney disease. And generally, we're thinking about dialysis when the GFR approaches or goes below 10 milliliters per minute per body surface area. And albuminuria is also very important. Normal is less than 30 milligrams per gram. Moderately increased is 30 to 300 milligrams per gram, and severely increased is greater than 300 milligrams per gram. So we will be talking about these different terms as we go through several talks in the series. Standardized office blood pressure implies that the blood pressure has been measured under standardized conditions. And we will talk about what standardization implies. For example, uh, having the back supported and not talking for 5 minutes before measurement, during measurement, and then avoiding caffeine, avoiding smoking, things like that. A routine office blood pressure is basically not standardized. Um, Manual blood pressure implies that the blood pressure is obtained using a manual auscultatory blood pressure cuff. Automated office blood pressure implies that you're using an automated device. Ambulatory blood pressure monitoring is obtained with a automated wearable device which measures frequent blood pressures on an intermittent basis. And then home blood pressure monitoring implies that the patient is using an oscillometric or manual auscultatory device to measure blood pressures at home. So how should you measure blood pressure? Probably the most important thing is reproducibility, measuring the blood pressure in the same way time and time again so that you can compare and contrast and trend your blood pressures. Oscillometric blood pressure device may be preferable to a manual blood pressure device. Of course, we should not forget lifestyle. We focus on blood pressure so much, and we focus on blood pressure medications and our blood pressure goals that sometimes lifestyle seems more elusive, but you should begin with lifestyle, which is targeting a sodium consumption of less than 2 grams per day, or sodium chloride of less than 5 grams per day. And moderate intensity physical activity is very important to achieve long-term blood pressure control. Again, moderate intensity physical activity is very important, at least 150 minutes per week, or to a level compatible with cardiovascular and physical tolerance. So what blood pressure target should we strive for? I think a lot of us get stuck on a particular number, but I think the most important thing will be individualization. Don't apply guidelines or targets blindly. Look at the patient, look at his or her cardiovascular risk, um, and his morbidities, comorbidities, whether they have diabetes, whether they have chronic kidney disease, whether they've had strokes, and how many medications are they on? Is it resistant hypertension? Are they on 5 medications, 6 medications? What target is appropriate for the patient that you're treating at that particular time? In general, for patients with chronic kidney disease stage 3 or less, the KDIGO guidelines recommend a blood pressure target of less than 120 millimeters of mercury. And we'll talk about what this target is based on, what data, what available knowledge supports this blood pressure target. We'll talk about that. And when should this blood pressure target be applied? When should it not be applied? When is it appropriate? When is it inappropriate? So this is just how to standardize blood pressure measurement. Um, and so I won't go into too much detail, but this is essentially how KDIGO recommends standardization of blood pressure measurement. So in the next volume of this series, we will go into the KDIGO guidelines themselves, and we will delve into the blood pressure target of 120 millimeters of mercury and why KDIGO wants that target, how is it justified. And it's actually a very interesting, stimulating discussion. Today was just an introduction. Next session will be a full-fledged immersion into the KDIGO guidelines. See you next month. So I will always end these hypertension talks with a couplet of the month. A couplet is poetry that is that expresses a reality in 2 lines. The couplet of this month is by me, and it goes, "This field is not for those who are prone to falling. Medicine is not for the fragile-hearted." Thank you very much. See you next time.